Hello everyone, very good evening to all of you. Welcome to the third part of the most important topics. So today we are going to discuss important topics, the last series, and definitely there will be a question from these topics only. Whatever I have taught you likely to be asked from these topics, and please watch my other playlist in this live lecture also. So before I start, I would like to know that am I visible and audible to all of you so that I can start. This will be like a question answer series and I will be explaining some of the important topics. So can I get a quick confirmation? Thank you, Mr. Apoptosis. So let's start. Question number one. I will give you half minute, and let us see how many of you can give a good answer or correct answer, right? And then we will be discussing about that topic. So an 80-year-old male has suffered with the heart disease and cardiac atrophy. On microscopy, perinuclear brown colored deposits were seen, as you can see in this diagram also. There are perinuclear brown deposits, right? So there are perinuclear brown deposits. Which of the following pigment is responsible for this? So what should be the right answer? Thank you, Nikhil. Thank you, Nikhil. Thank you, Killer. Okay, very good. So Keller came with the killer answer. Answer is C. Very good. So the correct answer is lipofusion, right? So what we have to remember about the lipofusion. So correct answer is lipofusion. What is lipofusion? What is lipofusion? Lipofusion is also called as aging pigment. So you might be knowing that this is also called as aging pigment, also known as wear and tear pigment, right? So wear and tear pigment or aging pigment. So these are the names of the lipofusion, right? So lipofusion is also seen in the, you know, as I said, the normal aging. But remember, this will be also seen in the atrophy of the myocardium. So atrophy, when you are going to see in the myocardium, so atrophy of the myocardium also it will be seen, right? And that is the important MCQ also, which examiner will be asking you. Atrophic myocardium, which pigment will be seen? So that is the lipofusion, right? So older individual, because here in the history you can see the individual is older, 80-year-old, right? He is having heart disease with cardiac atrophy. So because of the atrophy you can see an older patient, so it is most likely it is a lipofusion, because perinuclear brown color deposits, right? Perinuclear brown color deposit, can you tell me what will be the differential diagnosis? In the comment box, can you tell me? If I say that there is a brown pigment in our human body, what will be the differential diagnosis of the brown pigment? What are the two pigments you will think first? What are the two pigments you will think first? One is the lipofusion, right? And second is the iron pigment. So that is how your mind will be working, right? If you are having a brown pigment deposition, so we will think that it can be lipofusion or it can be iron deposition. So how to discriminate this thing? Can you tell me in the comment box how we are going to discriminate whether it is a lipofusion or iron pigment, because both will be perinuclear brown pigment? In the comment box, can you tell me how you are going to differentiate this thing? Lipofusion, we are going to see it is having lipid, so we are going to see the special stain for lipid, right? So special stain for lipid will be used for lipofusion, whereas a special stain for iron will be used for iron. So what is the lipofusion special stain? So special stain for lipofusion or for lipid is oil red O stain, right? So oil red O stain, this is the best stain, right? And other stain which we can use is Sudan black B, or simply Sudan also we can write Sudan black B. So these are the two important things we can use for identification of the lipofusion, right? And for iron, what we can use? For iron we will be using Pearl's Prussian blue stain. Pearl's stain or it is also called as Pearl's Prussian blue stain. Pearl's Prussian blue stain, right? And what we need to remember whenever we are going to apply these stains, right? So please remember, oil red O, that lipid will be red in color. Sudan black B, lipid will be black in color, and Pearl's Prussian blue iron will be blue in color. So the name itself is giving you all the hint, right? The name itself is giving you all the hint. No, it is not melanin. It is not melanin, right? So now you understood the brown pigment around the nucleus, older individual, atrophic myocardium. So there will be only one diagnosis, that is the lipofuscin, right? So that will be the lipofuscin. And whenever you have a brown pigment in your exam, you must remember that brown pigment is having two differential diagnoses. It can be a lipofuscin, it can be a lipofuscin, or it can be iron. If it is a lipofuscin, you are going to use a special stain for lipid like a oil red, Sudan black B. If it is iron, it is Pearl's Prussian blue, so that will be the blue color of iron. Right now you will see, as I have said, these are the perinuclear brown color, right? Now we have to confirm. So now you can see there are two stains I have written. So can you tell me what is the number 1 and what is the number 2? Now you are seeing the red color. So can you tell me which one is the oil red O stain? And can you tell me which one is the Pearl's Prussian blue stain? Right? So this one, where you are seeing the red color deposits, these are the oil, and this special stain is oil red O stain. And remember, this oil red O stain is the best stain to identify fat in frozen section. So please remember this question also. In frozen section, best stain to identify oil or lipid, your answer should be the oil red O stain, right? So answer should be oil red O stain is the best stain to identify lipid on frozen section. So this is very, very important. Frozen section lipid, frozen section for oil or lipid detection, your answer should be oil red O stain, right? And second one is Pearl's Prussian blue stain. Very good. So now you all have got it. So this is the Pearl's Prussian blue stain, which will be telling you about the iron. So Pearl's Prussian blue stain is used for iron. So this is for iron determination, right? Now come to the next question. A patient was planned for transplantation. He has a twin brother who is matched donor for him. This is which type of graft? That was previous year question also. Tell me what kind of graft it is. Very good. So I can see many of you are giving correct answer. That is great. Right. So first answer I have got from the killer. So that is the isograft. So this is the isograft, same individual, right? So when you are getting the donor from the twin brother, so that is the isograft, right? Autograft means from the same, right? So from the same individual, so our own skin, right? So from the individual itself. So when it is individual itself, it will be autograft, and isograft is the grafting from the twin brother. So whenever you take the graft from the twin brother, so that is called as isograft, right? So answer is A. Let us see about all other grafting, right? So what is autograft? As I said, from the self. So when we are taking our own skin from one place to the another place, that is auto means self, right? Syngenic graft. So please remember, syn means same, iso, right? So syn means same, iso. So syngenic graft or isograft, both are same. So what examiner can do in the next exam, they may not give isograft word, they will be using the word syngenic graft, right? So whenever you are taking the graft from the identical twin or clone, that is called as isogenic or isograft or syngenic graft, right? Allograft, allo means different. So it is, but remember the species is same. Species is same, but individual is not from the brothers, right? Something who is not brother, non-identical. So non-identical individual means is not belonging to his family, and same species means human being, right? And xenograft means from the different species, means some from animal you are taking the some graft and you are implanting on the human being, that is called xenograft. Xeno means a species, so when there is a different species, that will be the xenograft, right? So here I have shown you with a diagram which will be clearly understandable by you. Now you can see that both are having similar colors, so they are the twins. So these are the identical twins, and whenever you are giving identical twins, these are called as isograft, right? So now you got it. So number one, I am showing you isograft. Isograft means from the identical twins, as you can see in this case, right? Now number two, you can see autograft. Autograft means same individual. So you have taken the skin from here and implanting skin here, so that is called as autograft, means from the self, right? Autograft means self, right? Now you can see this individual and this individual, by color you can see both are different. So when you are giving but both are human being, so they are same species, right? So now you understand, they are same species, both are human being, both are same species, right? So when you are giving the graft from the one individual to the different individual of the same species, that is called as allograft, right? So now you understood. So same species, that is called as allograft. So this is the allograft, right? And now you can see this is the cute pig, and if you are giving from the pig to this human being, so that is called as xenograft, right? So this is different species. So now you can see that fourth one, that xenograft is from the different species, right? So now you understood this point. So these are the four types of the transplant we have to keep in mind. Now moving on to the next question. A 55-year-old male was having chronic renal failure and he was on hemodialysis from past 7 years. Which of the following amyloid deposits will be expected in this patient? Hemodialysis, 7 years, chronic renal failure, which will be expected in this patient? See, chronic renal failure, hemodialysis. So first correct answer I have got from the Praveen. Praveen Kumar has given me the first correct answer, that is the D, right? So whenever there is a, see, what is this? This is the renal failure and hemodialysis, right? So whenever you see a history of the renal failure and hemodialysis, so you will be having hemodialysis associated amyloidosis. And what is hemodialysis associated amyloidosis? A beta 2 microglobulin, right? So this should be the right answer. Now come to the this one. This AA type is called as secondary amyloidosis, right? AA type is called as secondary amyloidosis. Secondary amyloidosis, where you will see? Secondary amyloidosis, where you will see? It will be seen in the chronic inflammation. It will be seen in the chronic inflammation. And in chronic inflammation, most commonly in which chronic inflammation? That was the question again. So your answer should be in rheumatoid arthritis. Rheumatoid arthritis is most commonly affected, because it can be seen in other infections also, like TB, osteomyelitis, or bronchiectasis. So these are the various other examples where you are going to see the AA type of secondary amyloidosis, right? So you have to keep that in mind. Secondary amyloidosis will be having AA type of amyloid deposition, right? And this AA type of amyloidosis, I'm talking about AA type of amyloidosis, which is secondary amyloidosis. This will be also seen in renal cell carcinoma. So that is very, very important point, right? This is also seen in renal cell carcinoma, because kidney should not be confused with the always hemodialysis. See, history is very important. See the question, see the language. Question is chronic renal failure, hemodialysis. If examiner says chronic renal failure, hemodialysis, your answer should be A beta 2 microglobulin. But suppose question would have been like this: a 55-year-old male suffering from the renal cell carcinoma, which type of amyloid will be deposited? Then your answer will be AA type of amyloid. Now you understood this point. So whenever examiner asks you, right, about the hemodialysis, then your answer should be D, A beta 2 microglobulin. Mutant ATTR, right? Transthyretin, mutant transthyretin. Where you will see, can you tell me in the comment box? Mutant transthyretin. I want to see that. Who is giving the first correct answer? Mutant transthyretin is seen in which disorder? Which amyloidosis? Mutant transthyretin, yes, very good, Praveen. It will be seen in familial amyloidotic polyneuropathy. So please remember, this will be seen in familial amyloidotic, right? So familial amyloidotic polyneuropathy, right? So familial amyloidotic polyneuropathy, you are going to see the mutant transthyretin, right? And A beta, can you tell me A beta will be seen in which disorder? Anybody? Yes, very good, Sabyasachi. So please remember that mutant transthyretin is seen in familial amyloidotic polyneuropathy, right? And A beta is seen in the brain of Alzheimer's disease, right? In the brain vessels of the which disorder? Alzheimer's disease, right? So in Alzheimer's disease, we are going to see A beta type of amyloid. So all these topics which I have written, they are all very important. Here I would like to add on one more thing, that when you see a wild type of transthyretin, wild type of transthyretin, so do not get confused that wild is not mutant. Please remember, wild means non-mutant. So it is non-mutant transthyretin, right? So wild type of ATTR, wild type of amyloidosis, non-transthyretin, and that will be seen in senile systemic amyloidosis. That will be seen in senile systemic amyloidosis. Senile systemic amyloidosis is also known as senile cardiac amyloidosis, right? So this point I hope you will remember, right? So these are the important thing you have to remember. Now here I want to show you a one very important thing, that is the congruent staining, which came in your exam previous year, right? So congruent staining is a stain which we use to confirm the diagnosis of amyloidosis. Please remember, it will confirm the diagnosis of amyloidosis, right? So it will confirm the diagnosis of amyloidosis. But what we have to be very careful, congruent staining, what examiner is asking, you have to be very watchful, right? What examiner is asking, congruent staining, if examiner says congruent staining is under ordinary light, now understand, under ordinary light means what? Under ordinary light means under light microscope. So now you understood, if examiner says under ordinary light means light microscopy, and light microscopy amyloid diagnosis is never confirmed. Please remember, light microscopy, ordinary light, you are going to see red pink color and they are non-diagnostic. So now you understand this point. Red pink color is non-diagnostic. Why it is non-diagnostic? Why it is non-diagnostic? Because of presence of this red pink color is not only for the amyloid. Now understand, it is not only for the amyloid, it can be hyaline, it can be fibrin, it can be collagen. So there are different things which can be red or pink in appearance on ordinary light. So congruent staining, light microscopy or ordinary light, it is not diagnostic of anything, because it can be anything. It can be amyloid, it can be hyaline, it can be fibrin, it can be collagen. So this will not confirm the diagnosis. So now understand, this is not confirming the diagnosis. That is the very big problem with the ordinary light. So how we can confirm the diagnosis? To confirm the diagnosis, you have to use the polarized light, right? So whenever you are seeing them under polarized microscopy, with polarized light, polarized microscopy, under polarized microscopy with polarized light, then we will find apple green birefringence. So this apple green birefringence will be diagnostic of amyloidosis. Now I understand. So whenever examiner asks you, congruent staining will confirm the diagnosis under which light? Under polarized light, under polarized microscopy. And what will be the appearance? Apple green birefringence. So now you understand what will be diagnostic. Apple green birefringence will be diagnostic under the polarized microscopy. Now you can see this. This is a picture of the congruent staining. Can you see this? So all these extracellular, acellular pink material which I am marking with the arrow, these are all amyloid. These are all amyloid. So now you can see that this can be anything. It is not only amyloid, right? It can be anything. It can be fibrin also, it can be hyaline also, it can be collagen also. So that is why this is the ordinary light mine, right? So it is non-diagnostic, right? So it is a congruent staining, no doubt, but this pink material or red material which we are seeing in the extracellular area, they can be amyloid, they can be fibrin, they can be hyaline, they can be collagen. So that is why light microscopy is non-diagnostic. Pink or red color is non-diagnostic. So what will be diagnostic? This will be diagnostic, where you can see this apple green, right? So now you can see these are apple green birefringerences. Though this question came in previous year exam, this similar diagram, right? So polarized microscopy, congruent staining, polarized microscopy, apple green birefringence, this will confirm the diagnosis of amyloidosis. So I hope you got this point, right? So congruent staining, polarized microscopy, that will confirm the diagnosis of amyloidosis, right? Now coming to the next question, PRPSC deposition is seen in. Tell me what should be the correct answer. PRPSC deposition is seen in. Very good. So PRPSC deposition will be seen with. So Praveen has given me, Praveen and Sabyasachi, they have given me the first correct answer, that is the A, Creutzfeldt-Jacobs disease, right? So what is A? A is a Creutzfeldt-Jakob disease, right? So Creutzfeldt-Jakob disease is an example of prion disease, right? So prion disease will be having PRPSC is a prion, abnormal prion protein. Remember, this is the abnormal prion protein. Abnormal prion protein, right? So abnormal prion protein will be forming the misfolding. So you can also remember that prion disease is a misfolding of the protein disorder. So prion disease is a misfolding of protein disorder. So misfolding protein disorder is a prion disease, right? It will affect the neurons. I will discuss detail after some time, right? So let us finish about other option. What are the things you need to remember? Rabies, can you tell me what will be the diagnostic finding in the cerebellum or the brain? What we are going to see in the rabies? Rabies, we are going to see Negri bodies, right? So in rabies you are going to see Negri bodies, and cerebellum is the most common site. That is why I have taken the example of cerebellum. Parkinson's disease. Parkinson's disease is again a misfolding protein disorder, right? It is again a misfolding protein disorder, and here you are going to see misfolding of alpha synuclein. Alpha synuclein, and this alpha synuclein is going to form a named body called as Levy bodies, right? So Levy bodies are seen in the Parkinson disease, right? So Levy bodies are seen in Parkinson disease. Alzheimer's, if you look at the Alzheimer disease, what we are going to see? Can you tell me? Alzheimer disease, this was previous year question in the FMGE exam. Alzheimer disease is a disorder of the tau protein, right? Tau protein. Tau protein will be again here, it is also misfolding protein disorder. So they will be getting misfolding, and then they will be forming a protein which is called as neurofibrillary tangle, right? So that is how neurofibrillary tangle will be formed because of misfolding. Neurofibrillary tangle. So not only this one, there is a also misfolding of the protein in the Alzheimer disease which is called as alpha actin, right? And alpha actin misfolding will be forming the another important known body which is called as Hirano bodies, right? So now you understood this point. This is a very, very important thing to understand. Levy bodies are in Parkinson disease, right? and hieranobodies are seen in Alzheimer's disease, right? And when we talk about PRPSC, that will be seen in the Creutzfeldt-Jakob disease, which is the correct answer, which is an example of prion disease, right? So that is how you have to remember. So now understand Creutzfeldt-Jakob disease, prion disease, rabies will be having Negri bodies, Parkinson will be having alpha-synuclein, which is a Levy bodies, Alzheimer disease will be having tau protein neurofibrillary tangle, and they are having alpha-actinin in the form of hieranobodies. So let's see something about the prion disease. When we talk about the prion disease, it's a progressive dementia with a longer incubation period. It may vary from the months to years, right? So that is very, very important. It will be extending from months to years. That is why it is written longer incubation period. What is this? This is caused by infectious protein, right? So what is that infectious protein? That infectious protein is prion, right? That infectious protein is prion, which we have seen, PRPSC, right? So it can be sporadic most commonly, and it can be familial also, right? So what is the route of infection? So it can be iatrogenic or through the infected brain consumption, right? So iatrogenic is most commonly due to the neurosurgery or corneal transplantation, and infected brain consumption, those who are eating animals whose brains are infected with the prion disease, right? And what is pathogenesis? As I said, pathogenesis of prion disease is a misfolding of the protein, right? So that is the misfolding of the protein, right? And in this, what we are going to see, PRPSC will be there. See, PRPC, when you see this C, right? So remember, this is the normal prion protein, alpha helical sheet, and they are protease sensitive. So they are normal, alpha helical, protease sensitive means protease can digest them. So that is why I said this is the normal prion protein. But after the infection or consumption of the contaminated products, what will happen? There will be a structural change. There will be structural change in the prion protein. So what will happen? Now they will be forming another group of prion protein, which is abnormal prion protein. So now it is abnormal prion protein. So why I am calling this as abnormal prion protein? Because now they are beta pleated and they will be resistant to the protease. So here protease can digest this protein and they can remove from the brain. But now when they will be converted into beta pleated form, they will become resistant to the proteases, right? So now this is abnormal prion protein. So what will happen with this abnormal prion protein? This abnormal prion protein, what they will do, they will be undergoing misfolding, because now they are excessive in amount, they will not be digested by protease, so they will undergo misfolding. So misfolding of protein will happen, and that will cause neuronal cytoplasmic damage. And this neuronal cytoplasmic damage will create so many vacuoles in the cytoplasm, and that is called as spongiform neurons, right? So spongiform neurons will be formed in the prion disease, right? So prion disease will be forming a spongiform neuron. That is very, very important. So spongiform neuron will be seen. So now you can see how this spongiform neuron will be visible. So the neuron, nuclei of the neuron, and these are cluster of grape-like cytoplasmic vacuole. So now you can see these are the cluster of grape-like cytoplasmic vacuole. So that is the reason for the name called spongiform neurons, right, which is seen in prion disease. So now you can understand who are the prion disease. As I said, Creutzfeldt-Jakob disease, Kuru, Scrappy, mad cow disease, fatal familial insomnia. So these are examples of the prion disease. What we have to understand is spongiform neuron will be seen in all of them except for the one. So here it is very, very important and crucial to understand spongiform neurons are never seen in fatal familial insomnia. So this is the only disorders where you will see the spongiform neuron. Fatal familial insomnia, there will be no spongiform neuron, right? So they will be having no spongiform neurons. So that was also DNB and NEET PG question. So examiner can repeat in your exam also. Okay, spongiform neuron is seen in all except, right? So Creutzfeldt's, Kuru, Scrappy, and fatal familial insomnia. So that time you have to remember fatal familial insomnia, there will be no spongiform neuron, right? Now look at this picture, and now you can appreciate how spongiform neuron will be there. So you can see these are the clear spaces, right? Cluster of grape-like clear spaces. So this is called spongiform neuron, right? So this is called spongiform form neuron of the prion disease, right? Fine. Moving on to the next question. Patient came to emergency room with fever and headache. On examination, he was having neck stiffness, and CSF analysis was showing you increased opening pressure, mild increase in protein content, normal glucose, and increase in lymphocyte count. Most likely diagnosis. Easy question because one option is none. Tell me, what should be the right answer here? Right. So Praveen and Sabyasachi has given me the first correct answer. It will be a viral meningitis. That's great. It should be very quick because why it is viral meningitis? Why I said it should be straight? Because of this thing, normal glucose level. Right? Normal glucose level will be seen in the viral meningitis. It will be decreased in TB meningitis, and it will be having severe reduction in case of bacterial meningitis. So in viral meningitis, normal glucose level will be present, and there will be increase in the lymphocyte count also. Right? Increase in the lymphocyte count will be seen in the viral meningitis, even though lymphocytosis can be seen in the TB meningitis also. Right? In bacterial meningitis, there will be the neutrophilia. So that is how you have to understand. Right? So lymphocytosis will be seen in the TB meningitis. So now I understood this point. So here I would like to explain something about the CSF analysis. Right? It's a very important table, and you will get one question from here. So be careful. First I will tell you normal features. Normally, if you see the gross, it will be having clear and colorless. CSF pressure will be 60 to 150 millimeter of water. If you look at the cells in the CSF, so many students they see they think that there are no cells in the CSF, but it is not like that. CSF will be having some cells like 0 to 5 lymphocytes per micron liter. Right? What are the important parameter you should be noticing is the protein and glucose level. Right? So protein level in the CSF is 15 to 40 milligram per deciliter. Glucose is 50 to 80 milligram per deciliter. So these are the normal value of protein and glucose you must remember. Right? Chloride level is 116 to 122 milliequivalent per liter. Now let us compare between the bacterial, TB and viral meningitis. When you see the gross fluid, right, bacterial meningitis will be cloudy or purulent, yellowish color, right? Yellowish because exudate like, because it is exudate like because they contain neutrophil. Right? Because bacterial meningitis will contain neutrophil which form the pus. So pus is yellow in color or cloudy in appearance. So that is why it is cloudy or purulent. So now understand, bacterial will be having neutrophilia. Neutrophil will be forming the pus. So CSF will be looking like a pus. They are not pus, but they will be like a pus. So cloudy or purulent. Same way in chronic TB meningitis, TB meningitis, there will be the fibrin. And because of fibrin, they will form the clot. And this clot will be looking like a spider web, which is called as cobweb coagulum. Right? So TB meningitis, characteristically fibrin will be present in the CSF. Please remember, this is very important MCQ. Fibrin will be present in the CSF, and that is the fibrin is going to form the clot, and that is why the name is cobweb coagulum. Right? But in viral meningitis, CSF will be clear. Sometime it will be hemorrhagic, but mostly it will be clear. Right? Now if you look at the pressure, because of the fibrin, because fibrin clot will be narrowing down, and there will be creating adhesion between the lumen, and that is why pressure will be maximum. So CSF pressure will be maximum in case of the TB meningitis. So maximum CSF pressure will be seen in TB meningitis. Then it will be elevated into the viral meningitis, and the least will be seen in the bacterial meningitis. Right? Cell count, as I said, neutrophilia will be present in the bacterial meningitis, but lymphocyte count will be increased in both the TB and viral. So who will be having maximum lymphocytosis? Maximum lymphocytosis will be seen in TB meningitis. That is the point you should be having very clear idea, right? So whenever lymphocyte count or cell count is increased, so remember, cells are made up of protein. That is why protein level will be elevated in all of them. All of them is having elevated protein level. All of them is having elevated protein level. But when we talk about glucose, glucose is normally 50 to 80, but it is markedly decreased in the bacterial meningitis. right? It will be having severe reduction. Whereas chronic TB meningitis, it will be decreased, mildly decreased. Whereas in viral meningitis, it will remain normal. So that is what I said. This two parameter, the protein and glucose, is very often asked in exam. So whenever examiner says that protein is elevated and there is a normal glucose level, so you have to think about viral meningitis. That was the question also, right? Now come to the next question. A 35-year-old lady presented with the slow growing thyroid swelling in the past 10 months. Histological examination was done and macroscopic image of the biopsy has presence of orphan Annie I nuclei. What is this patient suffering from? So tell me, easy question only. Right. So Sabyasachi has given me the first correct answer. So this is the simple cancer, right? Papillary carcinoma is the right answer, right? So here, this is the papillary carcinoma where you are going to see orphan Annie I appearance. Remember, papillary carcinoma of thyroid is the only cancer of the thyroid where nuclear features are diagnostic. So examiner can ask you this question. Nuclear features are diagnostic in which thyroid cancer? Papillary carcinoma of thyroid, right? Right. So these are the important. And remember, papillary carcinoma thyroid is most common cancer of the thyroid, and they will be having best prognosis among all type of thyroid cancer. Right. Cytology cannot diagnose which thyroid cancer? Cytology is not diagnostic. Why cytology is not diagnostic? Because follicular carcinoma diagnosis is given on the basis of invasiveness, right? So either blood vessel or capsule invasion should be present for follicular carcinoma of thyroid, right? Medullary carcinoma of thyroid, they will be having amyloid stroma. That is the important thing, right? So amyloid stroma will be seen in medullary carcinoma of the thyroid, right? So medullary carcinoma of the thyroid, you are going to see amyloid stroma. So now you can see what are the nuclear features which will be diagnostic. So number one, orphan Annie I appearance, as I said. So this, please remember, nuclear features are diagnostic in which cancer? It will be seen in the papillary carcinoma of the thyroid. As I said earlier, this is a very, very important topic. Previous year, this was the question, right? So papillary carcinoma of the thyroid, what are the nuclear features? There are three nuclear features, right? What are the three? Orphan Annie I appearance, nuclear grooving, pseudo inclusion. I repeat, orphan Annie, nuclear grooving, pseudo inclusion. What is the orphan Annie I appearance? Why it is called as orphan Annie I? So that was a cartoon, right? So you can see here, that was a cartoon, you can see, and her eyes are having no eyeballs, right? So that is why it is called as orphan Annie I appearance. Why it is called as orphan Annie I appearance? Because if you look at the normal cell, they will be having chromatin, right? Stippling of the chromatin you can see in this normal cell. But now in this papillary carcinoma, there are no nuclear chromatin. So because of no nuclear chromatin, right, because there is a no nuclear chromatin, so that will be giving you a clear appearance. So that is why it is called as optically clear nuclei, right? That is why it is called as optically clear nuclei, right? So optically clear nuclei because of lack of chromatin, so they will be clear, right? Nuclear grooving, there will be a line like thing which will be running across the nuclei, so that is nuclear grooving. Pseudo inclusion, why it is called as pseudo inclusion? Because it is cytoplasm which has come down into the nuclei or come inside the nuclei. So when cytoplasm is dragged inside the nuclei or cytoplasmic protrusion is present into the nuclei, that is called as pseudo inclusion. So these are the three key features of the nuclei which will be diagnostic of the papillary carcinoma of the thyroid, right? Let us see one by one. So papillary carcinoma of thyroid, you can see there is a blood vessel and the fibrous tissue. So this is called fibrovascular core. So because of fibrovascular core, it becomes a true papilla and we are calling it as a papillary, right? That is important thing. Then you can see there is a calcium deposition that is called Samoma body, which is not diagnostic, right? So Samoma body is a non-specific finding. But you can notice all the nuclei. Can you see all the nuclei are looking clear? All the nuclei are looking clear. There are no nuclear chromatin. So this looks like a orphan Annie. So this optically clear nuclei is called as orphan Annie I appearance. Right, now look at this cell. If you look at this cell, you can see the nucleus is having one line like this. So that is called nuclear grooving. Second point. Right, now in this cell you can notice that cytoplasm is coming inside and they are forming inclusion. So this is called pseudo inclusion. So now you understood these three findings: optically clear nuclei, nuclear grooving, and pseudo inclusions. So all these are diagnostic for which thyroid cancer? Papillary carcinoma of thyroid. Right? So papillary carcinoma of thyroid, we can give a diagnosis on the basis of nuclei. Right? Whereas in medullary carcinoma of thyroid, you need to remember, origin of medullary carcinoma is parafollicular cells or C cells. So that is why sometimes C cell carcinoma is also another name of the medullary carcinoma. So please remember, medullary carcinoma is also known as C cell type of carcinoma. So it can be sporadic or it can be familial. Sporadic will be unilateral, and very, very important, again very important MCQ, they will be associated with red proto-oncogene mutation. Medullary carcinoma thyroid is associated with red proto-oncogene mutation, right? And familial cases are associated with von Hippel-Lindau, NF, MEN2, and again red proto-oncogene. So you can see that red proto-oncogene mutation is associated with which cancer? Medullary carcinoma of thyroid. Which medullary carcinoma of thyroid? Both type, sporadic also and familial also, right? And how you are going to diagnose? As I said, in this you can notice these are all tumor cells, right? These are all tumor cells, right? These are all tumor cells. So these are nests of the tumor cells. You can say that nests of the polygonal tumor cells. And outside you can see these are the extracellular acellular amyloid deposition. So you can see these are the extracellular acellular amyloid deposition. So that is how you can give a diagnosis on HE section. So you are going to see the polygonal tumor cells, and in between there are extracellular acellular amyloid. So how we are going to identify this? How we can say that it is amyloid? We have to use Congo red staining and apple green birefringence. So you can see apple green birefringence will confirm the diagnosis of medullary carcinoma of thyroid, right? So Congo red staining, polarized light microscopy, and apple green birefringence of amyloid will confirm the diagnosis of the medullary carcinoma of the thyroid, right? So what is amyloid? Amyloid is made up of altered calcitonin. So these are the altered calcitonin. That is why this amyloidosis is called as A-cal type of amyloidosis, right? So medullary carcinoma of thyroid will be having A-cal type of amyloidosis. And what mutation you have to remember for exam point of view is the ret proto-oncogene mutation, right? So ret proto-oncogene mutation is associated with the medullary carcinoma of thyroid, right? Now come to the next question. A person with hepatic jaundice, deranged liver function, and this clinical finding. So tell me, what is this disorder? Easy question. Previous time this was the question in your exam. Tell me what should be the right answer. Simple question, very simple question. Oh, Prashant, you are getting confused. See the option again. Jaundice, liver function, I. Its first correct answer was given by Vijay Raj. Very good, Vijay. Vijay has given answer as a B, Wilson's disease, which are given by many of you. So here your answer should be the Wilson's disease, and what I'm showing you, these are the brown pigment in the eyes, and these are the pigment present in the decimate membrane of the cornea, right? And what is this pigment? This is the copper accumulation. These are the copper accumulation. And what is this disorder? This disorder is Wilson's disease, right? So this disorder is Wilson's disease. Decimate membrane of the cornea is having copper deposition, and what is this called as? This is called as Kayser-Fleischer ring. So this ring is called as Kayser-Fleischer ring, right, or KF ring. So Kayser-Fleischer ring will be deposited, right? So Wilson disease, definitely, I think some student has given answer Parkinson. Wilson disease is a risk factor. Is a risk factor for Parkinson's disease, right? Is a risk factor for Parkinson's disease. So please remember, don't get confused by that thing, right? So KF ring is present. So this is the Wilson disease. So answer should be B, right? So KF ring will be showing you the decimate membrane, Kayser-Fleischer ring, and KF ring, as you can see, it on clinical examination it can be seen like this, but remember it will be best seen by slit microscopy, slit lamp microscopy. Best seen by slit lamp method, right? And what is the importance of the Kayser-Fleischer ring? Whenever you find KF ring, right, so 99.9% cases will be having neurological involvement. That is the line of Harrison. You have to remember, neurological involvement will be present. So what I mean to say that if an ophthalmologist is observing a KF ring, what is his important role, right? He will inform to the neurology department that have to work up on this patient, because once you see a KF ring, patient will be 99% having there, or almost 100% will be having some neurological problem. So that is why neurology reference should be given for all the Wilson disease patient who are having KF ring in their eyes. That is the point you have to remember, right? So Wilson disease, some important point, because question had been asked so many times, and there are so many questions had been asked in this topic. So this topic itself is a very, very high voltage topic for FMG exam. Last 2 or 3 FMG exam, there was always a question from here. So first you should know that they are autosomal recessive. Chromosome is 13, and remember it is short arm, right? So Wilson disease is the short arm, chromosome 13 short arm, and the gene which is encoded on this is the ATP7B gene. That was the previous year question also, right? That they have shown the diagram of the KF ring and they'd asked which mutation will be present. So ATP7B gene, remember B, not A. ATP7B gene is present on chromosome number 13. So what is the function of ATP7B gene? ATP7B gene normally encode for ceruloplasmin, right? Ceruloplasmin is a carrier protein which combines with copper and excrete them into the biliary tract, right? So if there is a mutation, what will happen? There will be decrease in ceruloplasmin, because ATP7B encodes for ceruloplasmin. If ceruloplasmin is low, what will happen? Copper combination with ceruloplasmin will also decrease. And if there is a copper combination is decreased, so there will be less copper biliary excretion. And as a result, what is going to happen? So now you can see that ATP7B gene mutation is causing all three things: decreased ceruloplasmin, decreased combination of the copper with the ceruloplasmin, decreased excretion into the biliary tract, and at the end, in the end, there will be more copper accumulation in the liver and the brain. So liver, brain, and other tissues, and they will be also causing RBC damage, hemolytic anemia. So whenever right, so whenever there is a liver disorder and you are having hemolytic anemia in a patient, you must think about the Wilson disease. That is why I have written clinically, when you are working as a clinician and you are having a patient with a liver disorder and hemolytic anemia, you must try to rule out Wilson disease. That is the dictum you have to follow in your personal clinical life also, right? So what will happen in this patient? Usually they will be manifesting disease in by the age of 6 to 20 years, right? Yes, KF ring is pathognomonic of the Wilson disease. KF ring, yes, Vijayaraj, thank you, exporting. God bless you, Vijayaraj. It's a diagnostic finding, right? It's a pathognomonic finding of the Wilson disease. So 6 to 20 years. What are the 3 organs affected by them? Is the liver, brain, and eyes, right? So liver, what you are going to see, all kind of hepatitis, remember all spectrum of hepatitis, acute, chronic, fulminant, all type of hepatitis will be seen in the Wilson disease. So acute, chronic, fulminant, all type of hepatitis will be present in this patient, right? They will have macronodular, remember it is macronodular cirrhosis, and Mallory-Denk bodies, which is made up of cytokeratin. So please remember, Mallory-Denk bodies, which is made up of cytokeratin, will be also seen. Brain, they will be having basal ganglia damage. Putamen will be having atrophy and causing cavity. So that is why it is also called as hepatolenticular degeneration. If you see the Wilson disease, some places it is also known as hepatolenticular degeneration, right? So they are also given a name, hepatolenticular degeneration, because copper will deposit into the basal ganglia and they will be causing damage of the putamen, which will be leading to the cavity and atrophy. So because of this cavity and atrophy, this is also called as hepatolenticular degeneration, because they are involving basal ganglia nuclei, right? And when this basal ganglia nuclei putamen is getting damaged, so this create a risk for the Parkinson disease, right? So that is why Parkinson patient, we often try to rule out he should not have a previously suffering from the Wilson disease by checking the ceruloplasmin level, right? In eyes, they will be having a sunflower cataract and Kesher-Fleischer ring in the cornea, especially in the decimate membrane, which will be yellowish brown in appearance, right? So now you can see this is the Kesher-Fleischer ring, which is pathognomonic. And diagnosis, you have to remember most specific, gold standard, and special stain. So most specific is the urinary copper excretion will be increased, and gold standard is liver biopsy. How much? Copper should be more than 200 microgram per gram of the liver tissue. Remember, it should be more than 200 microgram per gram. This is the line of Harrison, table of Harrison. Because some books it is writing 250 also, but I am quoting here is this Harrison 20th edition line. Please check it again if you have any doubt. Otherwise, you can follow this. Copper level should be more than 200 microgram per gram. And special stain is rhodamine stain, where red brown color will be of copper, right? So serum ceruloplasmin will be decreased, but here you need to remember serum copper level is non-diagnostic of the Wilson disease. Now coming to the next question. This is the last question. A lady has been diagnosed with a breast cancer. Her biopsy report reveals the presence of tumor cells in a signet ring appearance. Mucin deposition and Indian file pattern is most likely suggestive of. So mucin deposition, signet ring appearance, Indian file pattern. So tell me which breast cancer it can be. Very good. So this is a very clear-cut question, right? So I think first answer given by Prashant and Vijay Raj, right? Very good. So this is the invasive lobular carcinoma. Invasive lobular carcinoma, there are two things you have to remember. One is Indian file pattern, or also called as single file pattern, right? Single file pattern, right? And second important thing you have to remember, along with this, there may be a presence of signet ring cell appearance, right? So that is the important thing, right? So let us see what is important to remember in the invasive lobular carcinoma. E-cadherin will be absent. E-cadherin is actually connecting two cells together, right? So whenever E-cadherin is absent, so two cells will be detached. So that is why cells are discohesive, means they are not attached, right? So when there is a E-cadherin, as I said, E-cadherin is attaching two cells, but E-cadherin is absent, so there will be no attachment. So this is called discohesive tumor cells. So because of this cohesive tumor cells, they will be following in a single line, and that is why it is called as tumor cells are arranged in a linear pattern, which is called as single file pattern or Indian file pattern. Now you understand? So because of lack of E-cadherin, discohesive tumor cell infiltrate the lobules, and tumor cells are looking arranged in the linear pattern, right, which is single file pattern or Indian file pattern, right? These tumors are multifocal, bilateral, and they have signet ring cell. So now you can see number one signet single file pattern, and number two is signet ring cell, because mucin is pushing the nuclei to the one end, and that entire structure is looking like a signet ring, right? So that entire structure is looking like a signet ring because mucin is pushing nuclei to the one end. So this is the invasive lobular carcinoma. So now you can see there are two patterns. Here you can see tumor cells are infiltrating and they are running in a straight line. They are running in a straight line. So this is called Indian file pattern or single strand, right? This is the one thing. Second thing, you can see invasive lobular carcinoma. All right, in this you are going to see signet ring carcinoma. So you can see this tumor cell, right? If I am pointing out this tumor cell and this tumor cell. Now you can notice that nucleus has been pushed to the periphery because of the presence of mucin. So these are two important areas showing you the signet ring. They are all signet ring cell. All these are signet ring. So invasive lobular carcinoma will be having signet ring cells because of the presence of mucin. Mucin is pushing nuclei to the one end, and that is why it is looking like a signet ring appearance. So before I close down, I would like to tell you about the molecular classification of the breast cancer, right? Because there was a question in 2019 FMGE exam from this. So try to listen to this molecular classification of the breast cancer, where we are dividing them into 5 groups: 1, 2, 3, 4, 5, right? Luminal A, luminal B, HER2, basal, and Claudin low. So luminal A and luminal B. First we will focus on luminal A and luminal B. So what is common here in luminal A and luminal B? Right? Luminal A and luminal B, what is common? Luminal A is and B, both are ERPR positive and BRCA2 mutation will be present. Right? So please remember, luminal A and B will be having ERPR and BRCA2 positive. Right? So that is common to both luminal A and B. Both are ERPR positive, both will be BRCA2 gene mutation positive. Right? Now what is the difference now? Luminal A is HER2 negative, but luminal B is HER2 positive. Now understand what is the difference? Luminal A is HER2 negative, luminal B is HER2 positive. And remember, second fact is wherever you find HER2 positivity, patient will be having poor prognosis. So luminal A is HER2 negative, so they will be having best prognosis. Whereas luminal B is HER2 positive, so they will be having bad prognosis. Is it clear? Now come to the HER2. HER2 breast cancer will be HER2 positive only. That is why HER2. So ERPR will be negative. So now you can see ERPR negative, HER2 will be positive. So as I said, HER2 positive means bad prognosis. Basal. Basal means at the base. At the base, everything will be 0. Negative. HER2, ER, PR, all are negative. Right? All are negative. So basal, all are negative. Basal and BRCA1 positive. And basal is having worse prognosis amongst the all cancer of the breast, right? So this is the molecular classification of the breast cancer, which I am telling you, where question came in your exam in 2019. And the fifth one is the Claudin low. Claudin is a marker of intercellular adhesion molecule, and Claudin 347 will be decreased in case of the Claudin low cancer, and there will be a decreased expression of E-cadherin molecule also, right? So now what we have to remember that Claudin low and basal are similar because they are all triple negative. So this is called triple negative because HER2 negative, ER negative, PR negative. Here also ER, PR, HER2 all are negative. So both are triple negative. So now I understand basal and Claudin low both are triple negative. But who is having worse prognosis? Basal is having worse prognosis. Claudin low will be having poorer prognosis. So now overall, when you see the molecular classification of the breast cancer, luminal A is having best prognosis and basal is having worse prognosis. Right? So this is the one question, right? BRCA2 mutation will be seen in luminal A and B both, and BRCA1 mutation will be seen in basal type of breast cancer. So these are all important point we have to remember. Probably I will be keeping one hematology class tomorrow, maybe. I'm not very sure about that thing. I will have to check my schedule. If there will be, definitely I'm going to put a small hematology class. Or already I have discussed in my YouTube also live classes. I have discussed hematology once. You can go through and you can just see it. So thank you so much to all of you for coming and listening to this. And my best wishes to all of you. Keep revising your notes. Don't worry about your exam. Stay positive and be confident. You will do it. Definitely it is going to be an easy paper for you. Whatever you have read, just revise them. Don't look out for any new thing. Don't talk unnecessary thing. Don't involve in any gossip. Do not compare yourself with anyone because everybody is unique, and go to the exam with the positive mindset. You